Testing. Testing. 1, 2, 3. 听得到吗？
听到。
听到。
OK， 好，看得到吗？
看到。
OK， good。飲茶。
飲茶。
ngantuk.
Good morning.
Good morning.
Hi, good morning, everyone.
Good morning.
Okay.
Morning.
Sleepy
Morning.
Who's missing? Only 12 here. Anyone missing?
Someone.
I think more than a few are missing, but I think we shall start with the presentation first. Later we see who comes in.
Steven,
And
Alex,
one more. Yes, two person are missing.
Ray. 3%.
Okay.
Ang Chun Ling Dada. Okay.
Somebody is coming in already. Okay, never mind. We can proceed, but before we start, may I know what is the real name of the patient?
Yuri.
Huh? Yuri. What is the patient's name?
Elizabeth.
Elizabeth.
Lian.
Elizabeth Lian. Okay.
Elizabeth.
Okay, you may start.
Okay. Good morning, Miss Indira and all my friends. Today is our Group C presentation, low vision cast discussion. Our group member is Mr. Siu Ko Ang, Mr. Nyo Yong Hon, and Miss Chao Ching Wen and Miss Lau Shet Ling. Next slide, please.
Yep.
So this one is regarding a retinoblastoma. So our patient is sorry, Miss Inda, you are recording already? Yes. Okay, our patient mean ELA is a female, 7 years old, is a preschool student. OKU card holder is no information. So this one patient is visit our clinic to visited, which is 30th of September 2022 and 11 July 2023. Next. So this one we divide the general history into 2 visited. So the first visited September 2022. So patient is referred from Thomson Hospital to our low vision clinic for further assessment. Complaint of blur of vision at distant and near, reading difficult, whole reading material very close to her face, depends mostly on left eye since young, struggle to recognize face unless they are less than a meter away, bump into things often in both familiar and unfamiliar place. Last incident is 2 weeks ago, usually when she runs and rush when walking. Difficulty navigating in unfamiliar place. Worry in drug. No problem with light to drug adaptation. This is the first visit. The second visit of about the information for general history is complaint of unable to read small print. Current glasses and magnifier doesn't help, so no using in any occasion. So the green color box is our try to highlight to what we can do in the best. we just recommend that it's good to specify whether unable to read small print at far or near. Near vision should improve with glasses. Next slide. So this one is about patient ocular history. The first visit, the last eye examination is 1 month ago at Thomson Hospital, then referred to Segi Eye Care for further assessment. Bilateral retinoblastoma seen infant. She has comprehensive treatment at Hospital Kuala Lumpur. The condition is currently stable. Current RX is prescribed reading glasses 2 years ago at HKL. Rarely used is because fine is not helping. It was helping when she was not schooling. Once start reading, then it doesn't work. Has a pair of glasses for far, but not much improvement. Had a 4 times handheld magnifier with illumination, brought from Shopee 3 months ago for schoolwork. Stopped using since a month ago as she find it's blurry. Use without glasses, see through better seeing eye, which is the left eye. Why buy from Shopee since she been attendance follow up with specialized. Diagnostic with acquired cataract 2 years ago, done cataract removal operation, developed posterior capsular opacification PCO and YAP LASIK was done in April. Cataract induced by medication or trauma, only for left eye. The green highlight is some information we may just add on for the ocular history taking. So the second ocular history was LEE March 2023 with ophthalmology. Outcome is visual axis clear, IOL stable, VA 6/12 in clinic. VA 6/12 belong to left eye only or both eye. Current RX, same glasses as last visit. So no wearing since it is not helping. Next. About the medical and family history, the first visit was no family history of retinoplasma, no significant eye disease in the family. Grandfather has cataract. Younger brother been having regular eye checkup, no eye condition. So same, the green boxes is some highlighting. When is the last medical checkup? Current on any medication? Family medical history or any systemic disease? The second medical and family history, last medical examination, February 2023 with oncologic. No on any medication. Natural birth, full term, no delay birth. Next. So this one is about task-related history. For the first visitor, she is attending international school, homeschool base. Watch YouTube on TV at home usually. Tend to move closer, but parents keep her distant at 3 meters from the TV. 50-inch TV, very useful. Not much difficult with color except with lighter hues or color. Takes a bit of time to figure it out. Sit in front of the glass. Teacher mentioned she can write from the whiteboard. Use a box's exercise books to write as she cannot write in straight line. Parent noticed that her vision has been the same until recently. Parent well aware of the condition and has all the previous record of treatment. Parents are keen on getting a video magnifier. The second visit for task-related history, she is attending international school, homeschool based. Only one of her classmates has autism. The rest are healthy. No problem with moving around in familiar place. With slow down in unfamiliar place. No problem identify clothes, looking at the mirror and eating. Like to play piano. Currently running in school, sensitive to music. Likes outdoor activities such as swimming, playing scooter. Nails cut by mother. No problem making friends. Extrovert. She felt that she's the same as the other, can accept the condition of her eye. Parents are being informed of getting small magnifier as they concern the damage in school. Next. So this one is our some highlighting what missing in the task related history. For the first visitor, does she able to turn on the TV by herself? Bump into things usually more on the right side or left. Is she able to eat by herself? Does she usually go out of the house, do sport, or stay home more of the time? Does she have, if she using normal pen or pencil to write, any marker or thicker pens? Does additional lighting help her vision at near? For the second visit, does she able to read the notes when she playing piano? What does she do to improve her vision? Larger print, closer distance? Is there any difficulty she finds when playing piano, doing sport like swimming and playing scooter? Next. Yeah, so this one I pass to my
Okay.
friend.
Okay, visual assessment on September 2022. This is as Jin Woon mentioned just now. This patient have magnifier 4 times 10 illuminated magnifier bought from Shopee, and present RX is plus right side plus 225, minus 200, assist 180, left side plus 0.25, assist 550, assist 180. And his distance, her distance, her distance, eh, her distance aided vision right side hand movement at 1 meter, eye divided out cannot fixate. Left side 1.18 logma, pinhole no improvement equal to 6 over 91. And both eye 1.01 logma equal to 6 over 72. And what missing here is are they using 3-meter chart or 4-meter chart? And for near aided vision, right side 25 m at 10 centimeter equal to N200, and left side 2.5 m at 10 centimeter, which is equal to N20. And both sides also same, 2.5 meter at 10 centimeter, which is equal to N20. On July 2023, she didn't bring her magnifier. Okay, her distant unaided vision right side hand movement at 1 meter, and left side 1.14 logma equal to 6 over 83. And they didn't measure both eye VA. Near unaided vision is right side 4.0 m at 10 centimeter equal to N32, and left side not available, both sides also not available. From here we can see it's quite a big improvement in right eye near VA, but not sure whether it is wrong recorded or not. And near VA, both eye not perform. Okay, color vision, okay, assessment on September 2022. Color vision in Shahara 1 over 14, both eye, only demo plate. And D15 couldn't perform. Pupil, pearl plus RAPD, keratometry or topography no perform. Amsler, right side unable to perform. Left side, no abnormality detected. And confrontation field unable to perform due to poor fixation. On July 2022-23, color vision D15 diagnosed tritonopia. Pupil, pearl plus RAPD, keratometry, right side, F only perform left side. Didn't perform for right side, we assume because right side couldn't fix and deviated out. And left side, the result is 7.9 mm, 42.75 diopters at 175 axis. And vertical is 7.22 mm, diopters 46.75 and axis 85. And cornea axis is 400. at 85 axis. And the perform ancillary chart, right side unable to perform and left side no anomaly detected. Okay, on September 2022, retinoscopy plus 0.50, hand movement at 1 meter, and left side plus 550, and 600, and 635, 0.9 logma, which is equal to 6/48. Subjective reflection, right side plus 050, hand movement at 1 meter, and left side plus 550, ASIC 100, ASIC 135, and the VA is 0.9 logma, which is equal to 6/48 also. And here doesn't mention any improvement with pinhole and what is the best corrected near VA. Tonometry not performed. On July 2023, retinoscopy plus 125 and 0.25 and 630, counting finger at 50 centimeter. Left side plus 500, ASIC 100, ASIC 130, VA 0.7 logma at 2 meter, which is equal to 6/30. Subjective reflection, plano, right side is plano, hand movement 1 meter, near VA not available. Left side plus 450, ASIC minus 350, ASIC 180, VA 0.7, which is equal to 6/30 also at 2 meter. And they found out left side when she can read 3.2 m at 10 centimeter, which is equal to N 225.6. Okay, left side near vision improved with collection. Eye care tonometry, right side 70 and left side is 11. On September 2022, OCT unable to view right side, left side optic disc and macular not clear. We assume because due to poor fixation or media opacity. Contrast sensitivity, perilopsin, right side unable to perform, and OS is 1.70 log CS. Low vision device trial, none, not prescribed anything. Patient was too young and parents were interested with video magnifier. On July 2023, OCT, right side retinoblastoma, thin neuroretina rim at didn't mention in how many quadrant. And left side is retinoblastoma, thin neuroretina rim, only 1 quadrant. Incomplete recording, how many quadrant in right side? And low vision device trial, plus 10 diopters, plus 12 diopters, and plus 14 diopters spectacle magnifier. And she find that plus 10 diopters was most comfortable and provide best vision at near. And near VA remain 3.2 m at 10 centimeter, but faster reading speed. From here, we suggest better to record reading speed with and without magnifier to compare how significant is the improvement. Okay, next. Shereen.
Okay. So for the differential diagnosis, for the first visit, that's September 2022. So our differential diagnosis will be bilateral retinoblastoma and left eye pseudophakia. So, and then for the second visit, right, on July 2023, our differential diagnosis also is the same, bilateral retinoblastoma and left eye pseudophakia. So, although the testing could be long for patient, right, it is still better perform slit lamp examinations to confirm the ocular health. So there's not, they are not noted that is there any cataract induced on patient's right eye or not. So this is we are curious about this part. And then for the management part, on the first visit on September 2022, the management will be explain current conditions to the patients. Patients has been relying mostly on her left eye to see. So for the optical management, there's no RX or optical devices were prescribed at the moment, but can be considered in the future. And then parents will introduce to a video magnifier, which can help patients for near tasks when she starts primary school. And then for the second visit, the management will be explained to parents that current condition is stable and no progressions on the disease. And then for the optical management, there's no RX or optical devices were prescribed, as there's no significant improvement in VA with the optical devices, and corrected RX at distance and near VA as well. And then parents is advised on iPad in apps magnifier and the settings to enlarge the text and apps icons. And then actually there's an increment in near VA with corrections. Binocular near VA and reading speed should be recorded to see whether the improvement is significant or not. Okay. So next, and then for the for the first visit, right, on the September, the management for the non-optical management will be special school were recommended to the parents so that she'll be able to cope in primary school. And then beside that, larger font size and prints, writing with marker pen or 6B pencils were recommended for her reading and schoolwork as well. Next will be a recommendations letter could be provided to the school if she needs special privileges, such as like additional time like during exams. And then next one will be reassure parents to not being over worried of her bumping into things as she's still young and unable to pace herself. The condition may improve as she grows older later. And then for the next visit, the second visit, which is on July 2023, the non-optical management will be prioritize larger font size and prints were recommended for her reading and schoolwork. So other recommendations to improve overall lifestyle for the patient, right? Actually may suggest like patients to get her a big monitor screen to watch YouTube instead of TV. And then the recommendations letter not only to have additional time, but also to have a larger print size reading material and get teachers to write a larger size on whiteboard also. Okay, next. So the follow-up schedule, right? On the first visit, September 2022, so patients are advised to come again 6 months later for routine eye examinations, and then low vision aid assessment and review patients' RX as well. And then for the on the second visit, July 2023, patients are advised to come again for routine eye examinations to view topography and disease progressions. So next, okay, I will pass to Kevin for discussion part. Thank you.
Okay, thank you. So basically, retinoblastoma is a very rare case where this is actually a eye cancer that cause affecting the young children. And it can be caused by the mutation of the RB1 gene, okay, according to the study. And there's two forms of, there's two forms of retinoblastoma. 40% is inherited and 60% is a non-hereditary. And for the hereditary types, basically often is bilateral and high risk of the secondary non-ocular cancer in the later life. And for the non-hereditary, there is a 60%, usually is a unilateral, and there's no family members and low risk of other cancers. So for this disease, basically the prevalence is rare and occur in about one in 15 to 20,000 live birth globally, and in the counts of 3% of all childhood cancer. Most cases are diagnosed before 5 years old, and overall 90% are diagnosed by age of 3 years. Okay, the risk factor basically is a genetical mutation of the RB1 gene. Environment factors as well in vitro fertilizations, insect spray, and poor living conditions. And for this disease, the prognosis, basically survival rate is over 90% in developed country, okay, with the early diagnosis and proper treatment. And prognosis depend also on the extent of the disease, the intraocular versus the extraocular spread, unilateral or bilateral involvement, timelines of diagnosis and treatment. So the vision outcome depends on the tumor site, location, and treatment. Hereditary cases carry risk as well. So secondary cancer, especially if treated with the radiations, reoccurrence in future offspring, okay, 50% if patients, parents are with genes mutations. So that is the image of how the retinopathy look like. Okay, so to monitoring and follow-up management, okay, we can do the regular monitoring, comprehensive eye check every 6 months to monitor further reoccurrence and complications, OTC fundus imaging annually to check the macular and optic health, and then visual acuity testing to detect early declinations, visual field test to monitor the peripheral vision loss. Number 2 is to protect the remaining or better sight seeing eye. The impact resistant glasses like polycarbonate prevent trauma, UV protection sunglasses to reduce long-term light damage, eye protection during sport to prevent injury, especially the in contact spots. And number 3 is maximize the current vision, ensure up-to-date prescriptions and low vision aids to provide. So this is very important also to improve the future's quality of life. Number 1 is to maximize and support the remaining vision. Accurate spectacles correction and low vision aids should be provided. Regular assessment and management of possible secondary complication in future. Number 2, support education and learning. Provide activity technology, assisting technologies, screen readers like screen reader, voice typing, tablets, and with a large text. School to develop an individualized education plan, IEP, customized learning and support plan developed for children with disability to ensure the child has equal access to education and sport tailored to her functional vision and learning needs, and as well as the emotions well-being. Foster the cognitive and social emotional development, and encourage learning through multisensory method, okay, like touch and sound. Allow her to participate in the group play, hobbies, and extracurriculum activity to provide supervision and safety. So to ensure, number 4 is to ensure the safety and mobility. Use home safety modifications like contrast color, non-slip surface on the floor. And number 5 is to maintain physical and mental health. Regular checkup and dentals like general health, monitor the physical social issue like low confidence to promote the more to reduce anxieties and isolations. So to the family, acknowledge the family members the emotion to promote acceptance and positive outlook to help to focus to bring up the child. Okay, then to allow the child to try things independently, and then to connect to them. Okay, occupational therapy help to develop fine motor skill like daily living skill, etc. Okay, government support as well is more important, and as well as the disability services like transport and finance. So set out the follow-up plan, okay, provide a clear follow-up schedule to them, empower them with the track vision changes and seek for help earlier, and often open communications like practice WhatsApp and helplines for the concerns and emergency. So this is the references for some of the findings. And we are open for the questions. Thank you for listening.
Thank you so much, Group C. Yeah. Okay.
Group C.
Yeah, well presented on the case. Okay, just to let you know, Elizabeth is actually when you see her, you won't feel like she's actually visually impaired. She looks very normal. She behaves very normal also. Okay, so she's like a cheerful girl that won't look like that she's having problem lah. Okay, okay. Now okay, the discussion is also very comprehensive. Okay, covering up all the aspects that needed, both for the patient and also for the family members. Yeah, so well discussed also. Okay, now, okay, as usual, we will have like a break with questions. Okay, so the question for today is when comes to retinoblastoma, right? It's very rare that we see this kind of cases. Okay, so and you have to understand the core behind this retinoblastoma. Okay, so that is the reason why I give you this question. Okay, number one. Okay, this patient is having a retinoblastoma. Okay, cataract, high astig, color vision problem. Okay, so there are four. Okay, her IOP is not affected based on the Amsler chart. Her visual field is not affected. Okay, I want you to find out how these four are related to each other. Okay, so retinoblastoma, cataract, high astig, and color vision problem. Why these four are related to this? I want the explanation behind that. Okay, what lead this retinoblastoma that leads to this three, or is it like a coincidence the patient is having it, or memang if let's say a patient is having retinoblastoma, they will have this, and if let's say they have these three symptoms, what are the things that we can expect when she grows up? Okay. Yes, Kevin.
Just now you mentioned high astig IOP, cataract,
No, no,
and
no. High astig, high astig, cataract, color vision.
IOP you say so.
No, IOP, no. IOP is not there.
Okay, okay.
Okay.
So,
So
three,
this,
yeah?
yes.
Thank you.
Okay. So we will discuss this. So we'll take a break until 10:15. Okay. So we will resume back with, I'm not expecting only group C to come out with the answer, but everybody else. As I mentioned, there are marks for your participation during the case discussion, right? So at 10:15, I want everybody to, come out with your own point and your own opinion. If let's say you want to discuss among yourself also can, but we'll see at 10:15. Okay?
Can each group take one session or?
Up to you. Yeah, can.
Okay.
You can do that way also. As long as we will be able to discuss this, and then we will see how we can actually manage the patient in the low vision clinic related to this. Okay, because when we know the connection, then only we know whether it is the right time for us to prescribe any devices or give any management for the patient and what we can expect when she start growing. Okay? Okay. So I'll see you at 10:15. Okay? Okay, bye-bye. You all can discuss.
So are we going to have in group? Hello?
开车啊，开车，
呀，
跟
因为
自己解
你
group
如
咯，还是什么？
果你也要有 breakout room 嘛，I think 在这边
breakout room
大家 discuss 就好咯。
啊，
大家 discuss
因为我觉得很多都是上网找的，那资料应该是快重复性的。
Okay, 那大家 everyone discuss together here 咯。Someone volunteer to do the record. 已经。
Hello，Good C 朋友。Hello，Good C，Group C。你们有没有听到刚才他的 cataract 啊？是 on
有啊
left eye 还是 both eye 啊？
来，你看那 slide
那个 slide 好像没有，他讲 only
有
on 那你一边啊 left eye 罢了。
哎，你去看他的那个 group 那边。
因为我在看着那个 slide 了。
他的 cataract 严重吗 ？grade 多少？他的 VA 多少的？
小斌啊，接不到你电话了啊，因为你是 line 啊。
没问
你
题
的。电话不可以接到那个。
可以。
严重吗 cataract？
反正他 cataract 是 remove 了的啦 ，Steven。
remove 了啊？
啊，他7岁吗？他5岁的时候 remove 的。
remove 了左眼呐、还是两个眼睛都 remove 了？
确定
哦 remove 了 left eye。
那有没有 cataract 啊？
没有 check 到，没有 check 到，没有 check 到。
OK。
他的 cataract 是 congenital 还是什么？怎么有这样小就有 cataract 啊？还是药吃到了？他是那个 retinoplasma 的药是吧？是 steroid 是吧？
这也不确定，因为 record 里面没有写。反正它不是 congenital 啦，它是 acquire 后天的。acquire 的。
他的 retinoplasma tumor 那个 tumor 多大哦？知道吗？
他的 cataract 是因为他的 chemotherapy 造成的 retinoplasma 不会直接造成 cataract， 只是他的 chemotherapy 会造成 cataract， 他的药会造成 cataract， 所以他 retinoplasma 的人 I mean chemotherapy 会 formation of cataract。
他做那个手术啊，刚才这样子说，他没有 implant lens 什么，所以他度数这样深的。
没有 record 了。有啊，有 shoulder left eye shoulder aphakia 吗？有啊。
有 lens implant 的了啊？
有啊
怎么还会有 aphakia 的？
什么 shoulder aphakia 不
是
shoulder aphakia 不是放了 lens 的意思吗？
它有 lens 啊，但是它很深嘛，度数嘛，对吗？
因为它有 retinoplasma。
它的 retinoplasma tumor 多大哦？多少 mm 有知道吗？有 MRI 的那个 photo 吗？
应该不会啦，有的话他们。
10点至下午1点钟，翠文和你们分享亲子课题、热门时事、各种生活资讯等。Melody 官方时间是由胃部保护为你领先，胃部天然配方，助你舒缓胃部不适，胃不好吃。
Hello，哎，不是 discussion 呢，播种了哦。
应该是老师还没有回来哦。
有点久哦。
这样你们听到我讲话吗？
听到。
听到。
没有加到。
哎，你们有找到什么资料吗？我看到很多都是 most likely due to 它的那个 long term treatment related 的 side effect 来的。
对，mostly
对啊
secondary 啦。
对，因为如果说你讲刚才讨论的那几个点的话呢，因为主要它这个是most of the thing 都是 related to life threatening 啊，所以它主要就是要保密，所以它会做很多那种关于 laser 啊、radioactive 啊这种这样子的东西，所以 secondary 就会有力度那种什么cataract 啊，还有那个什么其他丢毒那些 glaucoma 的问题啦。
History 那边有拿到他做 treatment 吗？因为我找不到。
哦，我没有了，我是自己上网找，就是什么东西导致到它会有刚才讲的那种 cataract 咯，因为 normally cataract 如果你讲 inflammation 的话，因为它不是在 lens inflammation 嘛，它是在 retina inflammation 嘛，所以 unlikely 它会那个东西 inflammation 影响到你的 lens 啊，很多血是不会 directly 的啦，它通常都是 due to secondary，刚才我们讲的了，它是有那种 LASIK 的 treatment，因为你要 remove 那个 tumor，它有好几个方法的，所以我这边找了的话，它都有5种，它 depends on 你的 tumor 有大有小，所以最常见的就是那种 laser 咯，就是它 laser 掉那个 part，或者 stop 掉那个 blood vessel supply to 那个 tumor。第二个叫做什么 psychotherapy，它是用一个很冷的科技的东西 destroy 掉那个 cell 这样子。对，第三个 radiation 呢，就像我们平时看到那种做那种radiation 的 therapy，通常这种情况都是 for 那种比较 medium size 的 tumor，或者是它前面那几个方式没有 respond 的，就是没有 cost 的时候，它就要 use 这个方式。So furthermore，因为这个长期还是会有用一些药，因为 baby 嘛，他可能不太吃药，所以医生都会直接打药，再打进他的身体，就主要是让他那个 tumor 萎缩收缩，或者是 something like prevent 它继续 grow 啦。所以这些药也会有力度那个cataract，这个是我找到的资料了。Then color vision 跟那个 high astigmatism 呢，so it's due to 因为它这个retinoblastoma，so 它是 infected 在那个 retinal cell 上面的，precisely 它会比较常见会在那个 cone photoreceptor 那一 part，so 它就是直接 directly 就会有影响到它那个 color vision 的 development 哦。Then of course cataract 也是其中一个，也会导致到 cataract。Of course，如果你讲 power wise 来讲的话呢，因为它很少会 directly 的，它主要是除非你的 tumor 是很大，导致到你的 eyeball shape 有 change，然后就会导致到你的眼睛会有 effective error 或者是 high astigmatism 咯。So 最常见是因为它在 develop 当中，它眼球也会 develop 嘛，所以变成因为你的视线或者是你的那个tumor 挡着你，所以它会有影响到它那个 development 啊，它的 grow，所以也会 contribute to 那个 refractive error 跟那个 astigmatism。So yeah，以上就是我看到的，不知道你们找到的是不是也是 similar？
就直接是一样哦，接近一样。通常都是 big retinoblastoma 的时候才会 induce 这些 issue 啦，minor 的时候或者是刚 initial 的时候这一 issue 的。
So the worst 的话就是 enucleation 哦，就是之前我去 Isaac 那个 posting 的时候有了，就是他会把整个眼球 remove 掉，那个叫 orbital implants 啊，他就会放那些 fats 啊，那种 fill 他的眼睛，然后到最后他会跟他做 prosthesis 哦。好，吃我的早餐先，你们继续。
Cerai betul kan? Cek key nama dekat sini cekkan dia amount kan? Cek sales. Buka yang ini. Lepas tu tekan nama dan saja kan?
Tekan nama?
Tak ada salah kan? So semua I update lah.
Lambat ni.
Buka kedai.
Hi, everyone. Suddenly become so quiet.
I mean, we are just finished this class.
Yeah, I
Everybody
was.
was waited.
Okay. Shall we start?
Sure.
Okay. So, I heard your conversation just now. You all divided into the group, right? To
No, we
discuss.
did not.
Oh, you did not?
No,
Okay.
and we are open to everyone. Not
Okay.
right.
Okay. So shall we start
Yeah,
the discussion?
sure.
Who
Yeah.
wants to start first?
Then I will go first lah.
Okay.
Okay. So from the info that I got from regarding this retinoblastoma, so that because of this retinoblastoma, it happens in the retinal cells. So precisely will be in the photoreceptor and the con cells. So that it's also will lead to the developments and damage to the color vision. So besides that, that related to color vision, it could be due to the cataract. So there are a chain reaction among all these symptoms. So we're talking about the color vision that is part of it due to the cell photoreceptor cells as damaged and also due to the cataract. So furthermore, to the cataract, it's not directly due to this retinoblastoma. It is more likely to a secondary from the treatment, such as the side effect, the radiation therapy and other drugs that it's induced to this, I mean, lead to these cataracts. So for the refractive error and the high astigmatism also showing that this is not the directly due to this retinoblastoma unless there is a very big of the tumor. So it's happens on the distorted shape in the curvature of the eye structure that it's affecting them. But most likely it's due to because the child is still developing, and that will be a growth and development due to this inflammation and the tumor cause that there's a lead to the microophthalmia, such as even the uneven growth and contribute to the refractive error, the astigmatism. So yeah, there are few treatments will be taking in this retinoblastoma. So the first is also a very common one is called the laser photocoagulation. So it's a strong laser beam to hit and destroy the cancer cells or the blood vessels supplying to the tumor. So this is the very common one without surgery and all. So the second one is called a cryotherapy. Cryotherapy is an extreme kind of extreme cold thingy to destroy the cancer cells. Okay, and then the third one, when it comes to the slightly bigger in size, the medium size of tumors, or those the first two is not responded, it's not working on it. So there will comes to this called a plate branchy therapy. Branchy therapy is it's a radiation therapy. So the fourth one that will be using a drug because baby cannot, just taking drug like this, they will just put a injection through the vein, and actually this is more to string the tumor. So it's more towards those with large size of tumor or multiple of tumors or even it's affecting in both eyes. So the last one that we hopefully it won't progress to that is an inoculation. So such as the removal of the whole eye. So this will need to have to be implant and also do a prosthesis artificial eye in the future. So in general, my conclusion is because this retinoblastoma, they are more concerning about the health threatening. So the practitioner and even the doctor specialists that were more concerning that how to monitor the tumor, how to avoid this tumor to be grow. So they will take a lot of tests and evaluation. So make sure this is not going to progress. Like if yes, they are the treatments that I listed, both that will be take count into it. So of course, the glaucoma and others cataract that will be common because documented secondary following by the radiation therapy. So the power and the color vision is due to, as I will explain. So that it needs a long-term follow-up. It is, it's a very critical for children. So that's all for my part here.
Oh, Ray, you can be a lecturer, Ray.
Oh, and reading already.
No, I mean
Thank
his
you.
explanation just go shoot to the rock. I mean it's went on like a rocket, went to the moon and then come back. Then he concluded everything. Thank
But
you,
I
Ray,
got one
for that.
Yeah, thank you.
Miss
Yes,
Indira, you
Calvin.
can pong pong already. We can
Yeah,
end this
I have
session.
if let's say I'm sick, I have someone to replace me for the case discussion. Yes, Calvin, you wanted to say something.
Yeah, I have one extra information. Actually, it might be possible to induce a secondary glaucoma as well. So whilst the blastoma be getting in severe cases or the size is bigger, so once the neovas will be growing upon the blastoma and also until the iris, we call that iris neovas lah. If like that, it will be induced the high IOP, then it will be induced to the secondary glaucoma as well. Extra information I can get, which I feel interestingly lah.
Okay, thank you. Anyone else wants to add on regarding the astigmatism power? Anybody?
Is it based on because of the surgery, anything to lead to secondary astig?
Sorry, come again. I don't get your point.
Due to the therapy or any like surgery to lead to the astig? No.
No, it's not because of the therapy.
It's because of the tumor pressure on the group. Then the chemotherapy then changes the cornea shape or what?
Almost there, but it is not because of the therapy. Almost there.
It is possible. Yeah, it's due to the change of because there is a tumor inside, the change of the fluid, so it's contribute to that, the high pressure.
Yeah, something like that.
Okay.
Okay. Anybody else have some additional point? I have one more question just now. I said like, what else we can expect the patient to have, in the future? Like Calvin have contributed one that possible to have, to develop secondary glaucoma in the future. Yes. Anyone else that found anything interesting?
The leukocoria?
Not at this age. No. Anybody else?
I said that like the retinal detachment as well, since it's growing huge, so that the inner part of the retina, there might be tearing or detachment on that. So that's the one I might be thinking of lah.
Possible. There are possibilities for that. Okay. Other than that, anybody?
Visual field.
Yeah, that is also will lead to vitreous hemorrhage, orbital bone hypoplasia, and optic neuropathy, and so on. This is can be
Orbital
related to that.
hypoplasia not possible, but then optic neuropathy, all that is actually possible. Okay.
Okay.
Because the pressure will cause a proptosis.
Sorry.
Proptosis, or the eye come out. What?
No, not at this age. Not possible for that. Okay. Anybody? Anything else?
How about bone and soft tissue damage? Radiation can affect the bone and soft tissue growth, especially in children, because of the radiation
Yeah, but we are talking about the
Oh, the
vision.
eyes.
Okay.
Is there any like affected to the optic sections?
Sorry, optic?
I mean the optic disc, optic nerve, or sort of that.
Yeah, all that will be affected because
Oh.
of because this is a cancer cell, right? We don't know how it is going to actually spread around. For the moment, they have actually kind of deactivated it, but we don't know how that will progress further. So that is definitely possibilities are there lah, but we hope it doesn't happen, but possibilities are there.
And also
Okay.
the mortality of the eye movement will be getting lesser, and so sort of that.
Possible if possible also. Okay, if let's say it's spread to the muscle areas, right? Then it's possible. Okay. Anything else that you want to add?
Not the cover one. It's most likely because this is a cancer cells, so it would and then spreading around. So apart from eye, of course, there be a chances to affecting the neural brain and even some other part of our bodies. So this will be the secondary if it's not
chances
not
for
covered by
it to,
this eye topic.
yes, chances for it to actually to spread around is possible, but this one is more like a focal lah, but we hope it doesn't spread lah. Okay. Anything else?
May affect the hearing loss due to the chemotherapy drugs.
Possible. Possible.
How about dry eye? Because patients like gone through like some
Radiations and all
surgery.
that.
Yeah.
Yeah, possible.
Yeah. Okay.
You cause a strabismus.
Yeah, possible. Okay, because she's already having the right eye. Okay, that's how you connect it lah. Okay, possible for strabismus if you see the right eye, right? Okay, it's only hand movement for the moment. Okay, that at one point of time we can expect it to actually, not having a fixation. So turning, either inward or outward, it's possible. Okay. Anybody?
It may cause the keratitis because the inflammation of the cornea due to the laser.
Inflammation of the cornea. Possibilities are there because it's a cancer cell, right? But it is not the major one, but yeah, acceptable.
And
It's
one more is enlarged cornea, the pupil size.
Enlarged cornea.
Okay, the pupil size.
Because according to her case, right, it is actually kind of like dormant already. So we can't expect it to. I mean, we are not expecting it to progress, lah, but we do know in the future whether it will progress or not. For the moment, her case is kind of like the cells are deactivated. So whatever vision that she's having, right, should be the same. If let's say her VA is like, for example, like 675 is the better seeing eye, 670 something, right? So we expect it to be the same. Okay, but why strabismus is after at one point of time when the eyes get tired, then the chances for it to, to turn, to one side is possible. So that one is possible to happen lah.
There is always worried about like if this one for long term, will the eyeball tissue like the uveal tissue get thinner and develop staphyloma?
Chances are lesser lah because her, as I say, right, her cells are dormant now, so possibilities are lesser lah.
So
Because if let's say it is still active, right, then we can expect it to get worse by time. But according to the parents' report, HKL told them, the doctors in HKL told them that, it's already, kind of removed and deactivated. So it will not further damage the cells. Okay, so not so possible for up to that level. Yeah, not up to that level. Okay.
So basically, it's affecting mostly behind the eye, the photoreceptors and the cones.
Yeah, that
cause
because
color vision.
the damage is already triggered, right? So that will continue, but in terms of because of the cancer cell, it's not possible, for the moment lah. But we don't know in future what will happen to her. Okay, so basically basically this case is a cancer cell, cancer cell in the layer at the back of the eye. Okay, so what will happen to this cancer cell is it actually develops, okay, it affects infants actually. Okay, she born with it according to her report. Okay, she born with it, and then that actually, the cancer cell that she has is actually damaging the most sensitive layer in the eye. So when it is damaging, right? So the development of the eye that's supposed to happen while she's growing from infant, to the current age, right? It is not happening fully because the damage is already altered the normal growth of the cell and also the normal anatomy of the cells that's supposed to be there. Okay, so that is the reason why we can see there is a drop in the visual acuity. There is a, but we didn't test contrast sensitivity, but contrast sensitivity also will be affected for sure. And then there is a color vision defect also on this kid, and also there is a high astigmatism, and she's already having a secondary cataract. Okay, all these are related. Okay, why do we have to know whether it's related or not, so that we know what to expect? Okay, if let's say, okay, like this case, the patient came in later, okay, after she already removed the cataract, then she came to us. But if let's say she, comes to us when she's, before the cataract comes, right? We should have predicted this earlier and do assessment annually or, with a follow-up of 6 months to see whether there is any development of cataract or not. That is the reason why I asked you, to see the relationship between this condition and also the cataract development. Okay, this is very important not only for this case, but also in any other cases. If let's say you get some unique cases, right? Okay, that rarely, seen in the, in the practice. Okay, so you have to take some initiatives to read through. That is the reason why you have to have a Kanski book. Okay, I don't know whether you have the soft copy of the Kanski book or not. Please get a soft copy at least, have it in your computer, laptop, or in your phone. So whenever you have like a patient with some unique, diagnosis, if let's say they come in with a referral letter or anything, right? Please, go read in the Kansky book, what is this disease is all about? What is the sign and symptoms? And what are the secondary conditions that will actually, that can be seen in this patient secondary to the problem that they are having now. Okay, it is important for us to know that so that we can do when we do the assessment, right? Okay, we do the proper assessment and the targeted one for the patient. Okay, so like this patient, if let's say she came earlier, when she's like 3 years old, 2 years old, for example, we should have actually done slit lamp. Like currently, when they came in for the visit with us, right? We didn't do slit lamp, we didn't do any visual field test because it was instructed by Dr. Sundar to only do the two things. Okay, that's why we didn't do the slit lamp, and we already know that she's under the ophthalmologist. Okay, and it's already tested when he gave the report to us. So we didn't do that. But if let's say the patient came blank, okay, then you have to do it. Okay, so that is one reason. And also, so that is related, how to actually handle a case. Okay, so if let's say you get a complicated case or something new, just open your Kansky book and get the idea of the the ocular conditions. Okay, we rarely see this retinoblastoma, Stargardt diseases, or even RP also. Okay, if let's say you have the basic understanding, when you have the case, at least you can handle them in a better way. Okay, that is number one. Okay, number two is how that retinoblastoma is causing the secondary cataract. Okay, so as what you all mentioned is the treatment. Okay, the treatments are the one that cause the cataract. It is not because of the retinoblastoma they're getting it, but because of the treatment that is given to them, chemotherapy, and there are many treatments. It's not only chemo, the drugs that they take, all that may induce the cataract. Okay, it doesn't mean that the patient will confirm have that. It may induce them to have that. So we have to be very careful in assessing them. So when you do sleep lamp, you have to focus on the lens, with some additional care, so that if let's say we detect anything early, we can actually record down and monitor the progression of the cataract. Okay, that is one. Next thing is about the color vision. Okay, so as I mentioned earlier, the retina layers are being affected. So we expect that retina layer that is being damaged is also could be the cone, could be the rods also, depending on the severity of the condition that the patient is having. Okay, so that also need to be tested. Okay, so that why we need to test this color vision, and also if let's say the patient is having some damages on the rods and all that, right? Why? Because that gives an explanation to the parents of why the kid is actually bumping into things. Okay, why the kid is actually having problem in the school in identifying colors or discriminating colors. Okay, we do certain assessment. It's not to solve the problem, but at least to explain the parents to have the better understanding of what's happening to the kids' eyes. Okay, so that they know how to react to it. Okay, sometimes parents think that only the retina is affected, the color vision shouldn't be affected, or she shouldn't be bumping into things, or she shouldn't be having problem in the dark rooms and all that. So they are not optometrists or they're not eye care practitioners, so they don't have the idea. So when you know the ocular condition and you know what are the sign and symptoms, so you should relate the complaint that the patient is having with the assessment findings, and also the understanding why this is happening to this patient with this particular ocular condition. So that explanation will clarify the doubts that the parents have. So as I told you earlier, low vision is all about consulting the patient, the parents, or whoever that is involved, to give them a better clarity on what's happening to the eye, because it is not done by all the practitioners, um, in the hospitals. If let's say you go to HKL, it's even worse. They only have like 5 minutes, to see the patient. So the parents would not have, the opportunity to ask questions. So this is the time that we can explain them why this is happening. This is the reason why. This is how is it related to the ocular condition, and we are reporting this based on our finding. Okay, so that need to be explained. Okay, so cataract is because of the treatment, and if let's say the patient is having the sight vision problem, or central vision problem, or color discrimination, or contrast sensitivity problem, like if let's say she's walking at the roadside, if let's say there are curbs between the road and also the walking pathway, right? It will be a different height. If let's say she can't appreciate that, that is because of the damage in the cones. Okay, so that need to be explained to the parent also. And the last thing is about the astigmatism. Okay, so this astigmatism is because of, okay, again there is a damage in the retina layer, okay, which cause the retina layer to be not smooth as how it's supposed to be. Okay, when it is not smooth, right, it is actually grows to the front also. Okay, so that in irregularities that we find, it is actually continuous to the cornea also. So that leads the patient to have an eye astigmatism. Okay, So this one also you have to understand to explain to the parents why the astigmatism is high, and also for your own understanding what is actually happening behind the eye that leads them to have this irregular corneas, which leads them to have the high astigmatism. Okay, so if let's say a kid come, right? Okay, if let's say they already been seen in HKL, not been seen in Dr. Sundar, they somehow come to us first. So once you already read this, you can expect that this kid, if let's say she comes at the age of 3 or something, when she comes to our clinic, you can expect that the astigmatism should be slightly higher. Okay, we predict that. So based on that, when you do retinoscopy, you know that it can be higher, or you want to do auto refers for the kid so that you get some idea of what could be the uh, what could be the astigmatism power. Then you do right, then you will get a better idea. If you look at the report, right, the first uh, appointments finding, and the second one is differ so much. The first one is it's about -5, if I'm not mistaken, the astigmatism power. And then the second visit, when they do red, it was only -1. But after they do the subjective reflection, it becomes -350. If let's say the students had idea that this will be a high astig, okay, possibilities for high astig, they would have actually, did auto refers, or, karato might not possible. I don't know if it's, um, kids, sometimes it's not possible to do, but they did it. Okay, topo and all that could have been done to get the right power. Okay, so if we have the understanding the whole case better, then we know what to expect through the assessment, and we only do the assessment based on that. Okay, this is a general guideline for you. But when we receive Elizabeth, right? So Dr. Sundar only wanted us to actually suggest a low vision device for Nian. So it's clearly written in the, he called me also, and also he gave me a referral letter written that only the low vision devices. Whatever that we did extra was the extra for our, effort only. Okay, we wanted to have that baseline at least. Okay, but the core idea is just to actually see whether we can help her with any devices or not. The father came for that. Okay, so that is the reason why we don't do all the assessments. So again, the guideline that I gave you is for a general patient. Okay, if let's say they come in without any referral letter, then you have to do it that way. Okay, if let's say the patient comes with a referral letter saying that we only want you to do this, then we do that. Okay, so that is the reason why the informations are lacking in this patient. Okay, did I cover all? Cataract, astigmatism, color vision. Okay, that is a question. Wait, let me read the question from Kelvin. Wait, I have a question. You mean what condition is what you explain first? Is it Kelvin? You're asking?
I'm afraid of if I directly tell the patient like, okay, as this finding is showing that we suspect of retinoblastoma, then casting for what is retinoblastoma, then we directly like explain like, oh, it's kind of the cancer thingy, right? So the patient will getting shocked. So should I explain like by explaining all the condition, then end up with the suspected retinoblastoma, or we can directly tell? So by by Miss Indra experience lah. So what can we do?
Okay, if let's say this patient came to me first, if let's say this patient comes to me first, what do? I don't do that. Okay, because I'm not an ophthalmologist. Okay, my expertise is okay. Yes, I do diagnosis, but I will not reveal this first. Okay, I will explain that. Okay, even for, did you see Jean the other day? Jean Wong patient?
Yep.
Did you? Yeah. Okay.
Yes.
Even him, right? He had, his case is even worse. He had some other cancers. I couldn't recall. Okay, it's even more worse. So when he came for our last visit, right? Okay, the previous visit before he sees you. So when we see that he's actually having problem in elevating his eye top and to move down the eye, right? He couldn't do it. And when I discussed with Mr. Azam, we doubt that something could be some cancer cells are developing in the in the visual pathways, which is pressing, which causing him to have this problem. We doubted that, but we didn't tell the mother. Okay, we said that okay, he has some problem in elevating and actually moving down his eye, and we did additional tests. We did health chart, we did motility test. We recorded down everything, and then we told the mother that he's having this problem. I think probably he need to see Dr. Sundar back to get the idea of what could be the reason. Okay, because when and then I called Dr. Sundar and then I told him that doctor, this is the problem. Okay, I suspect that he might have some growth or something which is pressing him. Then he said, okay, thank you for identifying it through the follow up. Then he'll say he will do the assessment. When he did the assessment, then he called me back and he said that after he saw Jean, he said that no, Indra, it is not that. He was having this since beginning, but just that we detected it now. So if I actually told the mother when I refer him to Dr. Sunderbag, that could have been a wrong information because I don't have the instrument to actually do the assessment correctly to inform the parents. So I wouldn't take the risk. I would rather go from my prospect only that the eye movement is like this. Okay, the power is high, and then she's having cataract, and then she's having color vision problem. There might be something is not right with the retinal layers. Maybe we can do a further assessment with the doctor. Then we doctor can actually let you know what is the real cause. So I would go for a milder way. Okay, so that will be my way of doing it because sometimes you assume something, it might not be right because we don't see the patient from day one. So we cannot predict anything based on what we see only. So the right person will be the ophthalmologist who have been seeing them since day one. So that will be my call. I hope I answered your question, Kelvin. Did I?
It's clear mindset now because we can as a conclusion, like we not like judging anything, just only we like discussing or consulting them with our finding only. So
Yes.
not consulting
If let's
because
say it's a
before.
simple one, right? Simple ones means scan, like a cataract. That one is like, our call also. So we can do it. If it is related to, retina, stuff like that, right? I wouldn't take risk, although I know, but, it's better for them to do it. Like cataract, simple things, if let's say it's a glaucoma, okay, and all that, we can actually, let them know, but not if let's say it's a deeper or more complicated. I will let the doctor who have been seeing them since day one to do the consultation related to the ocular condition.
Understood.
Okay.
Thank you.
Okay. Anything that you want to add on to what I say, or you want to ask questions before I proceed with some comments on the presentation just now? Anything? No, huh?
No.
Okay. So okay. Can I see the slides again?
Okay, just one.
Mm.
Okay, mana I could be. Let's see.
After I give the corrections, then we have one more discussion to this patient.
Okay. Have I shared the screen?
No, I think you need to click the share.
Yeah, I know. Just too many things on my computer. I need to put something first. Sorry, later put you everything. Got it?
Okay.
Okay, let me make it screen bigger.
Yeah. Full screen maybe?
Full screen? Okay, can. Here we go.
Okay. Can you go to the first slide?
First slide. Okay. This one.
Okay, next.
This
Okay.
one.
Okay. Her case is she's 9 years old now, yeah, right?
Yeah,
Since
based on the record
2006
card.
Yeah, 2016. So she came to us when she was 7 years old,
Correct.
right?
Mm.
Okay. Then, okay. This is just a guideline. Can you go to the history taking? Next slide. Next slide. Next. Okay. What we missed. Okay. What is missed in task-related history? You covered here. But I mean, for the upcoming presentation or for the other groups, you can add in as what the previous group did. Yeah, what was missed in the general history taking. You didn't because we didn't ask her whether she's a OKU card holder. You know, the 8 questions, right? Maybe you can highlight the 8 questions. Okay, so that we know what that can actually systematically let us know what we exactly missed to ask. Okay. So that can be added to the presentation that is missing in this presentation because I saw that in the previous group's presentation. Okay. And also, can you go to the VA findings? Okay. Okay. This slide, right? Okay. You mentioned that you don't know whether they use a 3-meter chart or 4-meter chart. Okay, based on the finding itself, you should know that the patient, they have actually used a 4-meter chart. Why? Anybody can answer? I know it's a 4-meter chart. Not because I was there during the, assessment time, but I know it's a 4-meter chart. Anybody can answer why?
Because it's not written any meters, that we will assume the pre-setting will be a 4 meters first.
Okay. Anybody else? Okay, almost there. Anybody else have other answer? Based on the left eye VA. Even the right eye and left eye VA also actually shows that it's a 4-meter chart. Why?
Because got the 8 and 4 like that.
Sorry?
For the like 1.1 for Loma is the 4 is he cannot see the line two missing.
Okay.
So
okay.
normally this one is under 4 meters.
Okay. So if let's say the maximum VA that you can get with a 3-meter chart, right? If let's say the patient see the first line, okay, 4 wrongs, okay, 4 letters is wrong. So the maximum that they can get is 1.08 at 3 meters. Okay, 3 meters, no need to write 1.08. If let's say they can actually, write the value more than 1.08, that means they have converted it with the correcting factor. That's why they can get 1.18 logma or 1.14 logma. So it's very clear that a 4-meter chart is conducted. Okay, this is, sometimes you cannot get it, but this is how you see whether they have used a 4-meter chart or 3-meter chart. Okay, so that is one thing that I wanted to correct. And the near VA is recorded as 25M. Is it for the right eye? Benjamin, you presented, right,
Yes.
Benjamin? It is 25M, is it?
Yes.
It is 25M, with... Okay, go to the previous slide, Kevin. Okay, it's 20, no, yes, no, the 3-meter or 4-meter slide. Okay, it's 25M, and then suddenly it becomes 4M. And this one is not available. Okay, so there is a confusion. So I agree with you. Maybe it is wrongly recorded. Someone is in the car.
习惯那个蛇去按。
GP
不管啊，你可以过你就过咯，过了你还要换一下爽一下，哪怕爽一下咩
？Okay, AC. Yeah. Sorry, it's okay. I don't understand anyway, Benjamin.
He's helping someone to cross the road.
Oh, that's very kind. Okay. If we see this one, right, the present RX, okay, it is 025 minus 550, which is actually, correct with, her condition. And then you go to the next one. Next slide. Okay, and also it tallies with the corneal astig that they got it in the next week, the next visit. Yeah. Okay.
Yeah.
Go on to the next slide. Okay, this is where the difference that we can see. The left eye now has high hyperope, okay, with a -1. Okay. This one is a bit doubtful because the astigmatism is not tallying. And also, okay, why do you think the power is actually changed? What could be the possible factors that leads to, other than our students, retinoscopy is bad. Okay, other than that, what other things that could lead to this difference of so much, from, low hyperope, high astig, now become high hyperope, low astig. Okay, other than the retinoscopy. Okay, if let's say the retinoscopy is wrong, but the subjective result also showing the same. Why do you think there is a contradicting with the our current glasses one?
You mean the become less plus?
Yes, now becomes more plus, right? With this, the September 2022, comparing to her, subjective refraction result, comparing to her current glasses, there is a huge difference. Am I right?
Yeah.
Okay, because her glasses power looks like correct because it tallies with the keratometer reading. Okay, but what our student got from subjective refraction is like, totally upside down. Terbalik. Why do you think?
Oh, the astigmatism rotate.
Why do you think there is a difference?
For hyperodes, the eyeball is getting longer. But only 50 deltas, very little, not much changes.
No, the previously,
Yeah.
no, the previous one was, go to the previous slide.
Plus 550.
Previous one. You see, yeah? The present RX for left eye is plus 025 minus 550. Okay, I'm not talking about right eye, the better seeing eye is left eye. So our concern is only left eye. So now you go to the next slide. Okay, previous, the keratometer reading. Previous slide. Okay, you see the keratometer reading, say cornea astig is about -4. Okay, astig is 85. Okay, go to the next one. Can anybody predict why the left eye subjective refraction on September 22 is different from the present RX and it is contradicting to the corneal astig? Anybody can explain that? That will be the next discussion. Think and let me know.
I think the wrongly performed retinoscopy, I think.
But the response of the kid also the same kan?
Shit.
Would it possible due to the ciliary muscle, it's not adjusting due to
Not
the
really.
inflammation to the eye, or maybe the pressure fluid in the eye, so it causes that. That is we meant earlier because there will be secondary to the glaucoma. Because other than that, besides the rubbing eye and all protruding eye, so it's more related to the internal of the eyes. It's likely to the lens or probably the growing of the eyeballs.
Okay. Okay. Anybody else? Oh, and if you see from this thing, right, we can actually learn something. A mistake that we shouldn't do. Okay?
Okay.
So anybody else? Hey, suddenly all hilang already?
Because of the cycle equivalence.
What balance?
The spherical equivalence, because it seems like the earlier one, the power is like much lesser, but the asterisk is high. And then this one is like asterisk lesser, but giving it
Correct.
higher sphere power.
Correct. So that is the reason why the kids feel like it's about the same. Because anyway, she reached the VA is about the same also. Okay, but it is not the optimum power. Okay, when you actually do the rat on these complicated cases, right? Okay, and this is the reason why I say that when you know the diagnosis of the patient, you have to, read your Kansky book, to get the idea of what this patient could have. Okay, so based on that, then you do the assessment. Okay, so and also when you do refraction, do not start from the scratch. Always start with the habitual power. This is the reason why. Because one is once you already read the sign and symptoms of this particular case, right? You already know that this patient is having eye astig. So if you already know that the patient have high astig and you already have the power of the current spectacles is about -5, you immediately need to do either autoref or kerato or topo first to get the idea of what could be the power and what is the axis. Okay, from there you can actually predict how much power that will be in that particular axis. Okay, so that will actually ease your retinoscopy and subjective refraction. Okay, so in low vision clinic, this is how we do it. Okay, we go based on the patient's condition, and then if you know that this patient will have high hyperop or high myope, then we do autoreference or kerato or topo first. Okay, for other patients, if let's say it's not involving the refractive error problem, but it is only affecting the contrast and all that, so this no need to be done. So that is the reason why you have to know this, and you know what you should do before you start with your retinoscopy. Get the idea first, and then you do the retinoscopy, because the reflex that you see from the retinoscopy is going to be very dim for this kind of patient. So chances for you to actually get the wrong axis, for you to neutralize the axis wrongly, are very high. Okay, so to avoid that waste of time, you're going to waste the whole process is actually gone wasted. Okay, in the first visit. Okay, because of this. Okay, so it is always to make things more efficient when you are dealing with low vision patients is through these steps. Number one, read about the ocular condition and see what are the problems that they would have, and only do that particular task only efficiently. Okay, and also if you see, as Ray mentioned, because the spherical equivalence is about the same, so that's why the vision is also not actually affected much. Okay, so that could be one reason why. Another thing is the girl is only about 6 years old or 7 years old when she came to us. Okay, I think 6 years old. So when she came to us at 6 years old, when she thinks that it's a, you give comparison lens, right? So the response is also not reliable. That is also the reason why the first visit's refractive error is actually not the correct one. Am I saying the right thing? Anybody has having a contrast opinion to mine? We can always discuss. No? Benjamin, you already helped your patient to cross the road? Okay, so okay, now okay, when it comes to the management, can you go to the management?
Yep. This is a management from the previous record. Yeah.
Okay, so we didn't prescribe anything, yeah?
Yeah.
We didn't prescribe anything because the parents, okay, the Dr. Sundar sent to us to prescribe her with magnifiers. Okay, but the parents already tried magnifiers earlier. Okay, so they're not keen in trying magnifier, and they're actually quite well-to-do family. The father is the owner of the Auto Bravia in the Kota Damansara branch or something. So they are quite well-to-do, family. So they are okay, to get this, video magnifiers and all that. So the parents came with a mindset that they don't want magnifier anymore because they think it's not helping her. Okay, from what they have bought it from Shopee and all that, they tested, it's not working. And also when we tested here also, it's not helping her much. So they were more keen on video magnifier. Okay, so when I actually gave them the quotation and all that, okay, and then they didn't decide because the mother was taking time to decide on that, because we don't. Okay, another thing that you have to remember, yeah, if let's say a patient wants to buy a video magnifier, there is no demo set, huh? Okay, this is one of the reason why I couldn't sell any video magnifier all this while. Okay, because the supplier doesn't give any demo for you to try, unless if let's say the patient takes initiative to go to MAB, but the MAB's one also is the older version. Okay, so the older version, if let's say they want to get the latest one, right, there is no demo piece. So they have to actually, just have to go through, the videos, whatever that they provided, or they go to MAB to try the older version. If let's say they're happy, then they can go for the newer version. Okay, so this is one of the reason, because the mother was asking me whether can get demo or not. Even for Jean Wong also, the mother wanted to buy one video magnifier, but because there is no demo piece, she also didn't get one for him. Okay, and also his vision is still good lah. Okay, so this was one of it, and then only in the next visit we advise on the iPad apps, because she already have one iPad. Okay, so we advise on that lah. Okay. Okay, so that is my side of stories, because I remember Elizabeth Lee and case. Okay, now what do you think should be the proper management for her now at the age of 9? What do you think? Anybody? Based on the findings, based on what we actually have done, based on the suggestions of this group's one, what do you think is the major priority for age at 9 years old that you think that this need to be given to her, or discuss with the parents or suggest to the parents? What do you think? And one more thing, she's going for the private school, right? Okay, I think some of you already know what this private school does. Okay, this one is this private schools, right? Like the one that Elizabeth is going, it's like a home-based school. Okay, it is like a preschool. In the preschool, it will be conducted in the housing areas, right? Okay, so they do the same thing. So it is very customized, okay, according to the performance of the kid. Okay, so like usually the kids who are actually attending these schools are the special population kids, okay, and those who are with impairment, okay, and also those who are with learning disabilities like dyslexia, slow learners. So this kind of kids, okay, they are private schools which is like conducted in a home base with with a qualified teachers, okay, who teach according to their capabilities, not according to the syllabus. Okay, they don't have like, okay, standard one you have to complete, standard one syllabus you have to complete in 7 years, standard two syllabus you have to complete in 8 years. They don't have that. Okay, so many patients that comes to our clinic or go to other places, if let's say financially they have no issues, right, they go to this private school. Okay, for the parents, as long as she can learn something, okay, or he can learn something, at his or own pace, right, they're okay with it. Okay, they don't want to actually them be put in a system and fighting to learn according to the timeline that is fixed. This is the concept of these private schools. So that one I need to mention, and you have to have knowledge about this, because there are many parents, the current parents, right, the current generation's parents are into this home-based school, if let's say their kids are having some, special issues where they are not like other normal kids, they don't want to send them to the normal school or even blind school. They want them to go to this private school, and there are many private schools are like this. Okay, so this is another thing that, one new thing that, though, I mean, some parents, I mean, those who are parents here, some of you already know about this, but those who are still single, who doesn't know what's this one thing you have to know as an optometrist. Okay, in low vision clinic consultation, you have to actually, tell the parents also that this kind of school also exists. That can be one of the option for them to send their kids to that kind of school. Okay, so this also can be suggested. This one I learned based on after I see patients in the clinic. Before that, I didn't know that these schools exist. And then only I start searching. Is actually in every state, every single district, they do have this kind of school, and there are many students are, are studying there. Okay. Okay, yeah. Am I talking to myself or anybody still listening to me?
No, listening.
Okay.
Listening, yeah. Listening, yeah. Okay. So make sure that you remember this point when you are dealing with kids in future. Okay, doesn't matter whether they're low vision or what, but if let's say you see patients who are with special population kids, right, or autism, Down syndrome, like Vicky, you have a lot of patients, right? Please do tell them that these kind of schools are existing. That private school is the one-to-one teaching, yes, correct. One-to-one, sometimes two-to-one, depending on the level. So it is more like individualized learning, okay, on their own time space. Okay, they have like a teacher that come and teach them. Okay, it's not like the whole day teaching. It is like, okay, today you learn this only for 1 hour, you're done. Okay, then the next day do another thing, and then it is not following like a syllabus in the normal schools. Okay, we have syllabus like KSSR, KDSM during my time. Now I don't know what syllabus they are following. Okay, that is actually, the way they actually push the kids to learn, the basics. Okay, so at their own time pace. Okay, whether that will lead to anti-social or not, again, it's depending what the parents want. Okay, so these parents, right, that I see in our clinic or in OACs, right, who are sending the schools, right, I ask them, what is the reason why, I am also curious, what is their thought process, right? So when I ask them, why do you send to this school instead of, the normal schools or blind school, they say that for them, as long as, this school is not only teaching them, about, how to count, how to read, or how to speak, but they also teach them the basic skills, how to use toilets, how to, take care of themselves, how to drink, how to eat. So they say it's like a wholesome thing that they get in one place. And also these schools, they are not being pushy on, completing the task or the education, the learning that they're supposed to complete within this particular year. So they're happy that the kid is learning on their own pace. Okay, so these parents are into that. There shouldn't be a timeline for them to complete the syllabus and all that. So that kind of mentality that they have. And they say that they claim that it's not going to be antisocial because only the school time that they will be in that kind of school. But then when they go outdoor, they still see people. When they go to, the relative's house, they still see the normal people. So they say that they think that this will not affect, their social interaction with others. Okay, only the schooling way is different. And another thing is they want to protect their kids from being bullied or from being pushed into the race of learning. So that's also another concern of their parents, which I think as a parent, what they're doing is right. Okay. But we don't know. Okay. Because this kind of homeschooling, right, just started like a few years ago. So we have to wait another 10, 15 years. What kind of, what kind of problems that this kind of kids will face in the future, we don't know. Okay. So we have to wait for, 10, 15 years, let people do research and tell that when kids who go to this kind of school, they face this kind of problems. Okay, so it's we have to wait for it lah. Okay, but it's the parents' decision. Okay, I don't comment on the social interaction or all that, but I did query, one of the parents who's kind of very close to me. I said, don't you think that she'll have in this and all that? Then she defended herself. Then she said, no, I still bring her out to playground. She still mingle around with my neighbor's kids. She still mingle around with my cousins with no problem. Just that I want to protect her from being, bullied and let her learn at her own pace. So I think it's fair enough for them. Yes, somebody wanted to say something. Sorry, who's that? No, okay. Okay, what we
Yeah, want to add on.
yes.
Like my son, he studied in a private school with a school
Okay.
compound.
Okay.
Private school, they do have a special class like the PKKI in a private school. So the children is learning basic ABC, maths, and they do simple cooking, performance on the stage during the graduation day. Yeah, actually is if affordable, actually private special school, the special class is one of the wise option
Yes.
for parents.
Yes. Okay. This one is up. They are also in the private schools, like Vicky said, and also like a Tadika schools. They have in the home. Yes,
Like a
in a
bungalow.
yes, like in a bungalow and all that. Okay. They are also like I don't know whether you all know or not, because when I was doing masters, right, I was actually doing research on dyslexia kids. Okay, dyslexia kids, and this in Malaysia there is a dyslexia association. Okay, where they have branches in many states. Okay, even in Klang Valley they got like 5 6. One USJ, USJ Taipan, and then they have in Titi Wangsa, and then they have in Shah Alam. Okay, so they have a few. It is like that. It will be like a double-story house where these kids, this dyslexia kid, regardless of their age, okay, they will learn at their own pace without following any syllabus. If let's say that kid is only wants to do the basics, only able to do the basic, learning like ABC and counting, right? Okay, so even at the age of 10 they will be still learning that only. Once they already master that, then only they will go to the next stage. Okay, which can be at any age. Okay, and also the teachers are experts who are specialized to that. Okay, the teachers that they have, right? So they, when they teach, plus minus and all that, they won't be teaching like, like how we do it. Okay, they will do special way for the kid. Okay, individually, if let's say this kid has to be taught in, with technique A, student B will not follow the technique A. She has to, teach in technique B. So it's very individualized. Okay, and they are grouped in the classroom based on their capabilities. Okay, how much they already master, then they all grouped in one group. If let's say they already master B, then all of them, that B groups will be in the B classroom. So it is very, so I have seen this. So I have, like, during my masters I've seen this. So when the parents explain to me, I totally understand, because I've been in the dyslexia schools for almost like 1 to 2 years. I visited almost all their branches, and I have sit with them and, see how they learn and how the grouping is done. Uh, how the system works over there. So there is no time pace for that, and there is no goal that they have to achieve this before the age of 17. No, so they have like, their own time pace lah. Okay, already go into the different zone already. What we were discussing, where were we?
Management.
Every time I discuss with you all, always out of the track one. I wanted to say something, and then the question comes, and then I go somewhere else. What I want to ask? Yes, Kevin, what did I want to ask?
Just like
What
you say
did I
about
ask?
9 years old, what the kid
Yes,
needs.
yes. Okay. what the kid needs. Okay, so anybody don't talk ready. If I talk, then we go different direction. Okay,
You have
anybody wants
mentioned
to
you mentioned everything already.
anything else that you think that we missed for this patient? Okay, now she's 9 years old. Anything that we need to, uh, you know, give some additional attention if let's say she come for follow up next time, right? That, among this, what do you think the priority, whatever that, Kevin has discussed, right? What do you think in terms of the assessment or management should be the priority when she comes next for next visit, for example? Anybody?
More about what is a female's age at 9.
Mm-hmm.
That need to know.
Ladies?
Yes, ladies.
Yeah, ladies want to comment on this? Anything that you think that in terms of vision, okay, or in terms of social interaction and all that, because she's actually a very, you see her, when you see her, right, you won't feel like she's actually visually impaired. She's like a very normal kid, very happy, very cheerful, okay, no physical deformities that you can actually, know that she's actually having problems, okay. So she's a very normal kind of girl, okay, but vision is actually very much affected lah. Okay, what do you think that you want to do if let's say this patient comes for appointment with you? What do you think that your focus will be on? Anything, even if you want to say that I want to do refraction also, you tell, but you tell me why you want to do that. I cannot call by your name also, so you voluntarily answer. Like if I call by name, if you setengah see your patient or customer, I cannot. Anybody?
Yeah, for
Still
me,
monitor
I
the
will
VA.
will monitor on the VA. That's very crucial because anytime will change due to the development, and
Mm-hmm.
we will also need to see how's the performance and related tasks. Lah. We will according to her related tasks and give her the best vision
Okay,
relatively. Lah.
VA and giving her the optimum correction. Okay, rating, Jennifer. You want to say
Yeah,
something?
just now say already for the monitor the VA or see whether is it the VA become worse or any remand.
Mm-hmm. Okay, anything else? I'm expecting, Kelvin to say something because he raised the issue just now.
I think I will do the topographer, check the corneal astigmatism.
Okay, that's important because we already know that this patient will have this high corneal astigmatism, right? Okay, if let's say we have the baseline, then we can monitor that. Okay, and if let's say, we see any progression, any thinning or anything, then we can do some management for that. Okay, then
It's good to expose the Perry and how to teach her to recognize the work by using her hand or that train her before I think she may getting blind in the future, isn't it?
sorry, what is
Blind.
it?
She may get blind, so we prepare her before she get blind. Teach her how to use the what you call that Perry, the
You mean
hand.
a teacher braille, is it?
Yeah, teach her Perry all
Braille.
that.
Okay.
Just in blind.
Her near VA is N20, right? N20, am I right?
Yeah,
2.5
if not
M.
mistaken, earlier is
Better sing.
20, and then second
Yeah.
time it's lesser, 30.
Okay, and 30, is it? Okay. So this one we have to monitor first, yeah. We cannot straight away suggest it to the parents. Okay. Okay, what I will do is, okay, we already have the first visit finding, then we have second visit finding. I will have the third visit finding. Usually this is how I monitor the progression. So second one is usually, doubtful. So if let's say the third one is showing that, the vision is actually reducing, then I will discuss with Dr. Sundar because he's the one referred to me, right? I'll discuss with Dr. Sundar, and then if Dr. Sundar say yes, Indra, Okay, this is actually, will get worse by time. And also, the condition that she has actually will make her vision worse. So I will suggest to him first, doctor, can I suggest Braille to this patient? If let's say, okay, I think you should, then I will do it. Okay. If let's say the patient is monitored by me only, right, I would make my own decision. But if let's say the patient is referred by ophthalmologist, right, I would not suggest anything out of my, territory without discussing it. Okay. So that will be the right way. You can, but you have to monitor for 3 times. And then if let's say it's getting lower and lower or getting worse and worse, then we have to do this. Discuss first with doctor, then only do. Okay. Anything else?
The patient is it suitable for wearing the RGP lenses due to the high astig?
Possible, but we have to get the right refraction first. Refractive error is still, we don't get the optimum one yet. So once we get the optimum one, then we can actually refer for the RGP and see whether that actually makes the vision better or not. Can be done. But she's too young, right, at that point when she came to us. So we couldn't make decision. And also the Dr. Sundar's, referral was very restricted, only for the vision devices. So we never do out, out of that. But yes, can be done, Jennifer. Okay, what else?
Sorry, Miss Indira. So which means that if let's say we are before we going to like just now like Jennifer said mentioned okay, patient is available for RGP lens. So anything also we have to refer to Dr. Sundra first, then
Yes.
only we
Usually,
prescribe,
if let's say
right?
he refer, right, I will discuss with him. Okay, he's a friend of mine, so usually I'll discuss with him. Doctor, I think that she needs, RGP lenses. Okay, usually he will agree with me, but because it is a ethical way of doing it, because the patient is referred by him, right, to us. So if let's say we want to attempt anything, we have to inform him first. Okay, not to get his approval, but it's a discussion, because that's how Dr. Sundar deals with his patients. So he deals the patients very closely. So even if let's say you mention the name, he will immediately know what's the case. So I will usually discuss with him. I'll say that, doctor, I think that this patient needs this. Okay, I think I want to proceed with this. Will that actually affect your, consultations or your, management? If you say no, then I'll continue with my job. So it can be done.
Okay, thank you.
Can we learn the play rather than refer them to MAB so we can
No.
need to get a license or how to learn
Yes.
the play?
You need to have a certificate to teach Braille. You need a certificate to teach white cane. You need a machine to do the Braille teaching. You need to have a special papers. Okay, so there is a lot of things. It's not only learning, but it's a lot of things. Okay, because it's not only about learning the Braille, but also typing, reading a sentence, reading a paragraph, reading a book. So it's a big stage. Okay, cannot be like, like school teacher, right? So they're certified to teacher. So similarly, Braille also the same thing. Okay, any more? I think that's all. And one more. Okay, as Kelvin mentioned just now, there are possibilities for patients to have, to get secondary glaucoma. So for that reason, okay, Van Herrick angle need to be measured, every time the patient comes in. And also the patient has to be tested with IOP. The previous one, we already have the first or second visit. I saw the IOP result. Okay. So monitor the IOP also. So if let's say there is any problem, any changes, then we have to, refer back to, the doctor for the general case. This one shouldn't be an issue. We just monitor from our side. And obviously Dr. Sundar would monitor from his side. But if let's say it's a, if it's a new case, right, then we have to do it. Okay. Any
So,
more to
Miss
discuss?
Indira,
Yes, Jennifer.
It's like just now you mentioned, show that the patient is tritronopia, right? Tritonopia.
Tritonopia, yes.
Okay, so how can we in the future, how can help or any like manage this color
Okay.
vision?
Patient will have color vision problem, right? There is no solution. There is no treatment. Okay. So there is no treatment for this. We can try tinted lenses and all that. All that is like if you have myopia, we give you glasses, we give you contact lens, it will correct your problem, right? But color vision is not like that. The tinted lenses that we if let's say we want to prescribe tinted lenses, right? The tinted lenses is it's only going to help them by 1%. It's not going to solve the problem. Okay. And that is actually going to give them the contrast to be higher so that they can know that these two are different colors. But whether this is blue or green, they don't know. Okay. That is what the tinted lenses will do. So first you have to know that. Okay. Number two, when it comes to color vision test and all that, we only want to know what is the problem of the kid so that we can tell the parents that, okay, they will have problem in this kind of activities because of the color discrimination disabilities that they have. That is number one. Number two, when it comes to the future, okay, like this patient, yes, her vision is very poor, so the parents already know that the future will be when she wants to select any job or anything, want to apply for anything or want to choose a course to study, they know it's very limited. But generally we do color vision tests, okay, for patients. One is to explain to the parents that when he or she goes to school, she will they will have this kind of discrimination of problems, not because they are lazy. So I have to inform the teachers that this kid is having problems, so please do not bully the kid in the school. Number one. Number two, if let's say the kid is like vision is 6/6 but have color vision problem, so the kid doesn't know that he or she cannot be a pilot, cannot be a police, cannot be a army officer or anything that related to uniform related job. But if let's say you don't tell the kids at a very early stage, that kid will have dream until the age of 17, already mentally prepare, want to be a police. Then when they go to the selection and then they fail the color vision, then only they would know that they have this problem. Okay. And because of this, they cannot do this. Okay. So we as an optometrist, we have the responsibility to let know them at early stage so that they don't have dream big and then get shattered later. So we tell the parents at early stage that, because of this, he or she cannot pick this kind of job or cannot do this kind of job. Okay, they can be optometrists. Okay, every batch there'll be one color vision defect students that we have, because it is not going to be affecting our efficiency in doing our job. But if let's say they are involved in uniform related jobs and or pilot, right, that will affect their work, so they cannot be. So we have to give them the awareness at the early stage. That is the only purpose of this color vision test, not to give any management. There is no management anyway. Okay, I hope I answered your question, Jennifer. Okay. Any more questions? If no more questions, then we will end the session.
Yes, me. I have questions.
Kelvin.
Yeah, Kelvin.
Yes, Kelvin.
So as say like we inform the patient at the early ages, right? So it won't be like we frame the ambitions of the children anyway.
No, we have to do it.
We
Rather
have to
than
do it.
getting disappointed at later stage, if we
Mhm.
tell them now, at least they know that their choices are limited. We are not saying that you can't do anything. They can't do a few things only. They can't be a police only. Police, army officer, pilot, this. Only these four. The rest of the job doesn't require color vision. Or they cannot be a technicians like maintenance officer. But do you know that our Segi maintenance, he's one of the 8 head of the maintenance in Segi. He is actually a colorblind person. I was laughing at him. I say, you have been working for 20 years in Segi and you are colorblind. So how do you differentiate the wires and all that? Oh, I use contrast oh, I asked my, my staff to actually, do that kind of job. So, mistakenly went into this. If let's say he was told earlier, right, he wouldn't struggle so much in his job. Okay. So that is one. Okay. So there's limited, things only they cannot do. Majorly they can do everything, can be admin officer, can do business, can be a doctor also. Okay. So there is no only limited for certain things only.
I see.
I think that should be okay rather than they regret it and later, because there are so many people who are having ambition to be a pilot since young. So if you don't tell them at early stage, right, they're going to have the dream and get shattered at the age of 16, 17.
Yeah,
Okay.
sometimes I feel guilty as well because we kill their ambition at first.
Yeah. Yeah, but it is better to kill earlier than kill later.
Yeah,
Okay. Or,
understand.
no, kill earlier rather than get killed later. Yeah, that would be the right way.
All right.
Okay.
Miss
Okay.
Indira, one
Yes.
question.
Hmm.
Do you have any idea what contact lens can help to pass Ishihara test?
No.
No.
But
The
there's
supplier can say a lot of things, but we tried on all the patients, and there's a research papers also saying that it doesn't work for all. Okay, how do I say? It's very subjective. Okay, but based on my experience, right, nothing helps. You can
cannot.
claim lah, this will do, that will do,
That
but if
that
you
time
if you bring the real colorblind people, right, and you test yourself, nothing works. I tried
yes
with
that
this guy. He was my guinea pig, this maintenance guy. I tried all lenses, all detail lenses, whatever that I have in mind, I tried all. Nothing works. He said, ni lagi teruk lah, you bagi saya ini semua. He said, my
the
own vision is better.
the
Yes,
case
yes.
about the CAS patient, right? Actually, CAS previously got prescribed the red glass, red coma,
Mm-hmm.
red tinted lenses, right?
Okay.
Actually, also doesn't work for the patient because
Okay.
patient first try is use the Ishihara, so they
Uh-huh.
fill the Ishihara chart. So the companies say that okay, last chance for you to interview, you go find the any prescription that can help you to improve the vision. But after they find out the red is can uh, help him for the differentiate the Ishihara, but
Uh-huh.
the company get HRR for him.
Oh.
That's why they feel the job. They're getting more struggle for the patient. So I think that the lens is just help only, not can for
It is
just
okay.
1%.
Yes, these lenses, right? It is not, that's why I'm again and again repeating these lenses, right? Okay, it's only going to give you the contrast that this is slightly different than this. Then, if let's say you have memory that the left side is red, the right side is blue, you know that if let's say without lenses, you feel like the left and right look the same. But when you wear the tinted glasses, the left side is slightly darker, then the right side slightly lighter. Then you know that they are two different colors. But you still cannot name that this is red, this is green. You understand what I mean or not? You will not be able to, get it right as like me. Okay, but you know that they are two different colors. The tinted lenses only make you to feel, to have that vision that telling that this and this is different, but you don't know what is this color and this color. For you, it's still that this is a maroon, which is actually a red color, and this one is maybe you see that this is a dark green when it is a light green. That's it. So you won't know the colors. Colors will be still the same as your own perception, but it will not actually let you know. So that's why I say
There's,
the tinted lenses or supplier can talk, until the roof, but nothing works.
I saw the internet. There's someone that can
Mm.
sell in, I think in Seremban or what.
Uh-huh.
Contact lens can help
Yeah,
to pass.
that is one place that I also saw, and then our student also asked me how they sell and all that. I said
Can, can buy or not?
I need to see the result. You can tell me that after where this Ishihara is taught forward to us without memorizing, then I will agree with it lah. Because theory can never go wrong. Theory can never go. Once damage has happened, that's it. Cannot do anything unless, like in future, you have like something to repair your retina. Then possible.
True.
But cannot lah. Let's see lah. We hope for the best in the future, but currently no lah. We will check the Malacca one.
How about
Malacca Seremban one.
how about
Come
the
on.
I saw
Yes.
the website or article that show the about US got the like colorblind glasses. Is it helpful or because that one is not red color tinted lenses?
And again, they never proved that they can actually pass
Oh,
the,
okay.
Ishihara.
Okay.
Again, contrast work. Maybe the
Okay.
contrast between the two colors is better. Okay, but if let's say they're using VR and all that, maybe AI is there telling that this is red, this is green, this is blue. Possible. But if let's say lenses alone, no. No, it doesn't work.
Contrast, I believe.
Okay.
Contrast, we see a
Yes.
lot of face help
Contrast,
a
you
lot.
tell me. Yes, you tell me the contrast is actually better for them to know that they are two different colors. Yes, I agree with that. But with that, if let's say they can recognize the colors, no.
Yeah, the
Tada.
protein.
Tipuan,
Yeah.
tipuan.
Yeah, I need to help one patient to get through the Ishihara.
Ah,
Mm.
because we tried with this colorblind guy, and he tell me everything. Ni thorough, especially the red one is like thorough, like thorough. This nothing works lah. We tried everything. Me and Mr. Lau, we tried. Nothing works.
Miss Indira, go and buy the contact lens. That's fine.
Yeah lah. We ask Egi to buy. Or you all buy, bring to our clinic.
Expensive, oh.
Yeah, it's expensive. That's why I say, why you want to buy something expensive if it is not working? It's only going to give the contrast only. If let's say, it can make you to pass the Ishihara, then okay, worth it. No.
I got
Yes.
the color
Yes,
lenses, but not pass on. I tried few color blind patient. Nothing work.
Didn't work.
Yes.
Didn't work.
Yeah, I got at my
Yes.
shop.
Yes.
the
Just
color
contrast
lenses.
only.
Yes, the contrast only lah. Okay.
Okay, thank you.
Okay. Good session. Thank you so much. Okay, we'll see next week, right? Next week, one more time with another group. Okay, before I end, I already uploaded all my lecture recordings for low vision and also for dissertation. Okay, for dissertation, I have one topic on manuscript writing. And some of you already start writing your manuscript. Maybe you can watch the video first. And also you can actually, look at the slides which I have already uploaded over there. Okay, so that you can have an idea on how to write manuscript, and then you can start writing ready according to the format suggested. Okay, rather than still blank, don't know what to write, how to write and all that, right? Because the lecture is going to be next week only, 24th or something, but I already make it available. So whenever you're free, you can already watch and then you can start writing a manuscript. And remember, remember to settle your, now is week 8. Okay, this is week 8. Okay, so you have to submit on your manuscript on week 14 Monday. Okay, so please discuss with your supervisor on data analysis, how to analyze. Okay, and then start writing a manuscript. Okay, and make sure that your manuscript is corrected by your supervisor at least 2 to 3 times. Okay, so that it is perfect. Next thing is our B Optum semester will be starting in 2 weeks time. Okay, 2 or 3 weeks time. So after that, the lecturers will be very busy. So if let's say you want to have a discussion and all that, right, try to make it within this 2 to 3 weeks, because we are still in semester break. So try to utilize these 2 to 3 weeks to settle your data analysis at least, okay, or start drafting your manuscript. Otherwise, once the semester starts, right, we wouldn't have this much of time to check your things and all that. Okay, so please do utilize this 2 to 3 weeks. Maximally use your supervisor. Can get your things settled. Okay, so that's all. Thank you so much. I'll see you next week. Okay, bye.
Miss Indira. Miss
Yes.
Indira.
Yes.
I remember last dissertation one, we have a form that we need to ask our, during
No need. I don't want any signature from the supervisor.
No need
Yeah.
already.
Because we already have a form. They will evaluate you in week 4, week 8, and week 12 on your progress. If let's say no progress, zero mark lah. So you no need to get their signatures and all that. No form, nothing. Okay,
So they
you
will
just
report
submit.
to you.
They will report to me directly.
Oh.
Okay.
Okay.
Thank you.
Okay.
Okay.
Thank you.
What
See
what
you.
else
Bye
we
bye.
still owe you, Miss Indira?
No forms, nothing. You just
No,
need to submit.
we still owe you anything or not for low vision? We not, all finished,
No,
right?
all finished. Okay, my low vision is only left with discussion only lah.
Okay, can.
The physical session, you just need to submit your report. There are a few that haven't submitted. They requested for extension. I already gave them extension. Okay, so once you submit, then done. You just need to
So
clear.
there's no other any case right up, right?
No.
No.
Some haven't marked yet. I cannot post in the spot, right?
Spark is just for evidence that they are using Spark. You just submit that. I will mark.
Oh, okay. Can. Yeah, because we try to put it back to the smart. Yeah. Okay, can.
That
No
one
problem.
is just put it in Spark. Then the physical one only you have to put in Spark. You know, right? The physical one I have created the session, so you just put it there. And then I will mark from there.
Okay.
Okay. So who's presenting should be in the group, right? In the Excel sheet. Just check on that. And okay, that's all. Bye bye.
Okay. Bye
See
bye.
you.
Yeah. Thank
See
you.
around.
Bye.
Bye.
Thank you.
Bye.
Thank you.
Thank you.
Thank you, Miss.
Bye.
Bye.
Thank you.
Welcome. Bye.
See you again.